Well, thank you, Ryan. Hello, everybody. This is a case review live session on cranial nerves. This is part two. Last time we covered cranial nerves from 1 to 5, where we were supposed to cover from 1 to 6, but actually we went out of time. So today we hopefully will be able to cover the rest of them from 6 to 12. Let's start by abducens nerve number 6. And here I'm showing you this case, and you have all the important images. You have T1 pre-contrast, you have a T2, you have an SWI, and you have post-contrast images in both axial and sagittal view. And just focus on the location of the lesion. This would be my next question. So based or according to the location of the lesion here in this part of the pons, let me take you to the next question. The first question is, which cranial nerve or nerves could likely be affected in this patient? A, number 6, B, number 5 and 6, C, 6 and 7, or D, 5 and 7. Well, so makes sense because it's the number 6. But actually, the answer is number 6 and 7. And here's my point. So now we're dealing with number 6. As you see here in the pons, lower part of the pons, where the nucleus of the abducens nerve is located here in the dorsomedial part of the pons, the nucleus of 7, which is more anterolateral to this one, the facial nerve comes and makes this loop around the nucleus of number 6. And that forms or gives a shape of a bulge here along the dorsal part of the pons, what we know as, or what we call, facial colliculus. So this facial colliculus is clinically important because a lesion here would affect both 6 and 7 together, what we call facial colliculus syndrome. And this is exactly what I what I mean by having a lesion at this place, this position, because as you can see here, the abducens nucleus is here, facial nerve nucleus is there, but it curves around the abducens nerve before exiting the pons. And of course, we have also other facial nerve nuclei, superior salivary and the nucleus solitarius, which will join the facial nerve later on. But again, the facial colliculus syndrome is when a lesion affects this part of the pons, dorsomedial part, so it gives you both 6 and 7 clinical palsy. And this is our case, and as you can see here, it's clear that we have a popcorn lesion that is bright on T1, surrounded by a dark rim, which is hemosiderin, and you can see the blooming here on SWI, and the lesion shows there is some sort of enhancement around the lesion that looks like an arborizing pattern or a medusa pattern of enhancement. And of course, apparently this is a cavernoma with a DVA in association with a cavernoma. You know, always when we see a DVA, we should search for an associated cavernoma, which is not uncommon with DVAs, and also vice versa. When you see a cavernoma, there might be a DVA that will not appear unless you give contrast media. Now, what are the segments of 6 nerve? You know, I want to come across anatomy whenever it's possible. So we start again by the nucleus here in the dorsal part of the pons, dorsomedial part of the pons. Then this will be the first segment, the nucleus and the brainstem part. The nerve will exit here at the pontomedullary junction. So at this place, the junction between the pons and the medulla, the nerve will exit here, and then it will course in the prepontine cistern. It will go this way. It will go superiorly and also laterally. So this oblique orientation is important in terms of imaging until it reaches the third segment, which is the segment along the clivus that enters the Dorello canal, which is an opening exactly located in the petroclival synchondrosis, as we'll see shortly. Then it goes in the cavernous sinus, and finally it enters the orbit through the superior orbital fissure to supply the lateral rectus muscle. This is the only muscle that is supplied by the abducent nerve. So if you look again, you'll see 5 different segments of the abducent nerve, and here we'll see some examples to cover these segments. So when you look at this image, these images, you will figure out what I mean. So when the nerve goes in the prepontine cistern in this direction, so it will not be possible to see the nerve as in the axial view as a whole segment. You will always see it as small dots, small dots. But the only way to reconstruct or to see the nerve in the axial view, as you can see here, is to tilt the axial plane, to tilt the image or the plane to be parallel to the clivus. Something that we don't do in regular regular practice, but it just for in terms of illustration, it's nice to see the nerve here that is actually has a right angle with the ICA, and then it courses, as I told you, cranially along the clivus before entering the Dorello canal and then the cavernous sinus, as we'll see. So, but the more practical thing is that to go cut by cut, section by section in a cis sequence like this one, CISS, so we can see the nerve here in the prepontine cistern, small, very small, tiny structure, and then it enters the Dorello canal, and you can follow up this from we can follow up the course of the nerve cranially in the prepontine cistern until it gets into the Dorello canal here. And that explains why a lesion in the prepontine cistern, whatever it's neoplastic infection or subdural hematoma, as in this case, would very likely be presented with an abducent nerve palsy. So what happens in the Dorello canal, and what's the Dorello canal? It's the junction here between the petrous apex and the basi-occiput. So the junction here between the petrous apex and the occipital bone, what we call petro-occipital synchondrosis or petroclival synchondrosis. Here is the Dorello canal. It's a tiny structure where the abducent nerve goes and courses into the canal and pierces the dura before entering the cavernous sinus. And that explains why lesions here at the petrous apex, basi-occiput, or located in this area in the petro-occipital synchondrosis will very likely give abducent nerve palsy, as you can see in this example of a cholesteral granuloma that you can see here involving the petrous apex, multilobulated or loculated lesion that is expansile. You can see it on T2 bright and also on T1. It gives a high signal or an intermediate signal on T1, something that is characteristic with cholesteral granuloma. But keep in mind or pay attention that cholesteral granuloma, there has to be expansion of the petrous apex. Don't rely on the signal, because it's not uncommon to find a normal petrous apex with high signal on T1 or on T2, either because of fat, bone marrow fat that could be prominent here, or entrapped fluid, which sometimes happens in the petrous apex. And by the way, it could be asymmetric or geographic in distribution. So the clue is always the expansion. Once you see the expansion and the multilobular appearance, then the diagnosis of cholesteral granuloma can be made, especially if you see a T1 hyperintense lesion. And that will lead us to the next question, number 2. The T1 hyperintensity in cholesteral granulomas is predominantly due to blood or fat or calcification or protein. Well, so we've got some split of the answer. And by the way, this question is, it's for those who are under residence training in residence radiology. So this is a basic, because it's a very common question that comes in exams. And actually the correct answer is blood. And because, whenever you see cholesteral, the term cholesteral can make you think of like maybe the lesion because it has cholesterol and fat, so that's why it's T1 hyperintense. But actually, it's predominantly because of the methemoglobin that is present in these in this lesion. Also, fat cholesterol crystals may play some role in this hyperintensity, but again, the main cause, the main factor is the presence of blood. What's the importance of this? The importance of this is that sometimes you're lucky enough when you have a lesion in this. Another case of cholesteral granuloma, again, lobulated lesion, expansile lesion at the petrous apex that is T2 hyperintense and T1 hyperintense. But if you're lucky enough to get this fat SAT image, if you can do it, and then you will find that the lesion is not suppressed on fat SAT T1 sequence, which means that it's not fat, it's blood. That will help you make your diagnosis, establish your diagnosis of cholesteral granuloma. One of the common lesions or important lesions that occurs in the petrous apex, and these patients also are presented with abducent nerve palsy because, again, the location. The location, remember that this is the Dorello canal. The petroclival synchondrosis means that the Dorello canal is here. The abducent nerve passes from this area, this part. So this is a patient who has a petrous apicitis. You see here the abnormal enhancement of the petrous apex and the fluid collection, which turns out to be pus on DWI. And these patients are presented with what we call Gradinego syndrome, that is characteristically has 3Ds: discharge, which is from the ear, of course, diplopia because of lateral rectus palsy, because of abducens nerve palsy, and deep orbital pain because there are also irritation of the trigeminal nerve, which is not far away from this area. See the mastoiditis here. So, and I'm giving you another example. Again, the location explains itself. The location explains why a patient has left six nerve palsy, because here's the Dorello canal again, and you see the lesion is enhancing at the petrooccipital synchondrosis, the clivus is expanding, and you have the prepontine extension of the lesion here. You see it on T2, it's bright on T2 with some internal matrix, if you will, and you have here the bone marrow infiltration on T1, and you have strong enhancement again on this coronal image. And if I trace the abducent nerve, it turns out to be a chondrosarcoma, which is very common at this location. The location is characteristic, and the imaging and the signal characteristics as well. And if I trace the nerve for you, you would expect why this patient would be presented with abducent nerve palsy. When the nerve enters the cavernous sinus, as you know, there's something unique about abducent nerve, that this is the only nerve that is located entirely inside the sinus, the cavernous sinus itself, like it's embedded in between the venous sinusoid of the sinus, the cavernous sinus, as compared to the other cranial nerves, which are invested in the lateral dural wall of the cavernous sinus. Could that be relevant or important? Yes, because in early cavernous sinus thrombosis, the abducent nerve is the early nerve to be affected because of this characteristic location. And that could be very helpful in this when you interpret or read this case. And I'm going to show you a real case with a lesion that might be involving the right side of the cavernous sinus. You can see here there is some sort of bulge in the right cavernous sinus that turns to be a cavernous sinus meningioma. And it was debatable if it is true or not. You see here, there's bulge here in the lateral wall, and there's some fullness here on this side of the cavernous sinus, and there might be something here, not sure. So everyone was like talking about, is this a true lesion or not? And then there is one feature that I emphasize that you should always, whenever you have a cranial nerve and you have muscle innervation by this cranial nerve, check this muscle, check the terminal innervation of the nerve, so that will support your diagnosis. So what do we have here? We have a small intercavernous lesion that was debatable, but it results in some bulging of the lateral wall of the cavernous sinus. But what else do we have? We have the expected course of the nerve, of course, and we have this. Look at the right lateral rectus in this orbit and compare it to the left side. Of course, you have atrophy of right lateral rectus muscle. That confirms your diagnosis. That helps you establish a diagnosis of right cavernous sinus something, because this is the expected course of the abducent nerve, and that's why there's right lateral rectus muscle atrophy here. Another example, maybe more subtle than the previous one, we have the pontine cavernoma. And again, if you look at the right lateral rectus muscle, you see relatively small side of the muscle compared to the other side. In the coronal, you will also you can compare the right side with the left side, and you see the difference. Again, looking at the muscle denervation or motor denervation because of cranial nerve palsy, cranial nerve, that will definitely help you establish your diagnosis. Now let's move to the next one, the facial and vestibulocochlear number 8. And here I have a case, and I will show you, it's a quiz case, and I'm not gonna ask you about diagnosis, but I will ask you about this. So the hint is to try to identify all the segments of facial nerve that you know. And I will scroll through the images. So this is important here. I will stop here. Okay, I will show you this one. So you can see parts of the facial nerve. Let me go back again. Let me go forth again the other way. And I will stop here. And I will show you also this T2 sequence, axial sequence of the same patient, where also you can see from above and below. So I will stop. I will go through the canal, and then I will stop here. I think you would be able now to answer the next question, which is, so which segments of the right facial nerve are involved by the lesion? A, cisternal canalicular, B, canalicular and labyrinthine, C, labyrinthine and tympanic, or D, tympanic and mastoid. Well, so yeah, so I've got one answer, which is so the correct answer is actually the tympanic and mastoid. And let's learn together the anatomy of the facial nerve. So, my opinion, all cranial nerve imaging skills require that detailed anatomy. But maybe the facial nerve, because it's a complex nerve, it has a complicated course inside the middle ear, labyrinthine, petrous apex. So all this require you need actually to know anatomy, detailed anatomy of the facial nerve, and I'll take you through this journey together. So first of all, we have here the tympanic segment, which goes this way, because you see this is here's the canal. You see here's the canal here. So the canalicular segment is clear compared to the other one, and then the labyrinthine segment goes this way. So this is the tympanic segment, and here is the beginning of the mastoid. This is the mastoid, and you have mastoid. It's full of fluid here, and you have the mastoid segment here posteriorly. So you have both tympanic and mastoid segment involved in this case. And now let me take you through this anatomical illustration of the facial nerve that starts with the cisternal segment here, and then the nerve enters the canal, and it goes in between the cochlea anteriorly and vestibule posteriorly. So this is the cochlear nerve, but actually the facial nerve will go in between them. And when you do a section here, a sagittal section in the canal itself, everyone should be familiar with this. You have four branches. You have four different branches. You have the facial nerve, and you have the cochlear nerve, both anteriorly, and you have posteriorly the superior and inferior vestibular nerves. And this one is much is more clear actually than the previous one. When you have here again the cisternal segment, and it goes to the cochlea and vestibule, and then, as I told you, the facial nerve will pass in between them. And this is the canal, where it's divided by the falciform crest into upper and lower halves, and it's also the superior half is divided by Bill's bar into an anterior facial and posterior vestibular. So the facial anterior, what we call 7 up, and the cochlear is anterior but inferior, and we call it coke down. So you have 7 up, you have coke down, and you have superior and inferior vestibular nerves posteriorly. So yeah, so so let's go to the next question. So the facial segments which are labeled in this image. So look at this image before reading the question. Look at the image here. We have labeling number 1, and you have number 2. So the facial segments which are labeled 1 and 2 respectively in this coronal image are A, canalicular and geniculate ganglion, B, canalicular and labyrinthine, C, labyrinthine and tympanic, D, tympanic and geniculate ganglion. Well, so we've got some sort of split here, but we have one correct answer. So it's the labyrinthine and the tympanic. And I'm going to show you, I'm going to teach you something that is actually interesting. So when you do coronal imaging of the facial nerve, you scroll through the coronal planes until you get this funny shape or configuration. You see, this is the cochlea, and these two dots here represent the labyrinthine and the tympanic. And you remember that by a snail's eye. The snail's eye configuration tells you that this one is the labyrinthine and this one is the tympanic when you see the cochlea here at this level of coronal plane. So what is that? So remember again that the facial nerve will go first into the canal, and then it will give you this inverted V shape. What's that? This is the labyrinthine. I told you it's between the cochlea, this is the basal turn of the cochlea, and the vestibule is here. So you have the vestibule posteriorly, and the cochlea anteriorly. Facial nerve will give the labyrinthine segment here. And then this dot is the position of the geniculate ganglion. So the inverted V shape is labyrinthine segment, the geniculate ganglion, and then the tympanic segment will start here, the other arm of the V, or the inverted V, and then the tympanic segment will go all the way along the medial surface of the middle ear cavity. So here at the level of the lateral semicircular canal, this is where the tympanic segment will go until it reaches the posterior wall, the mastoid, where it will form the mastoid segment later. And we'll see that shortly. And on the other image, I'll show you all the segments together. We have here the canalicular or the meatal segment, and we have here the labyrinthine, the inverted shape, the inverted D shape, and we have the tympanic, and then we have here the mastoid. And remember that the greater superficial petrosal nerve arises at the genicular ganglion, and the chorda tympani nerve arises from the mastoid segment. So you can follow, you can trace the facial nerve based on these and this information here in the middle ear axial view. Once you see the ice cream cone appearance of the incudum malleal joint, you can start seeing the facial nerve at the level of the lateral semicircular canal. So this is important. So you can see it here, starting here, tympanic segment, and then keep going. You'll see part again, another part of the tympanic segment. Again, we are at the level of the lateral semicircular canal. A characteristic and very helpful view is this one in the coronal image, when you can see the lateral semicircular canal here and the tympanic segment is just underneath the lateral semicircular canal. So please remember this plane. The facial nerve is here right under the lateral semicircular canal in the coronal plane of the middle ear. This is the tympanic segment. Once we go posteriorly, more posteriorly, you'll see the facial nerve here forming a facial recess. The facial recess is just before turning to form the mastoid segment. This is a coronal view. You can see the mastoid segment here until it exits at the stylomastoid foramen. So this is important. Why? Because when you see something like that, this is an uncommon lesion, venous vascular malformation of the facial nerve, hemangioma. It arises at the genicular ganglion. So when you see the genicular ganglion involved in a facial nerve pathology, you know that you're dealing with one of two possibilities, mainly. Number one is schwannoma. Number two is hemangioma. We used to call it hemangioma. The correct term is venous vascular malformation, but we call it facial hemangioma just for to make it easy. So how can I reach this diagnosis, this uncommon entity? Because I know the anatomy, I know that this is the canalicular part, and then it will form the inverted V here. So what's that? What's this part? This is where the genicular ganglion forms. So a lesion in the genicular ganglion will be either schwannoma or hemangioma. But because of this permeative appearance, because of this pattern of erosion of the bone here, so and the strong enhancement, so a diagnosis of hemangioma can be made easily. So again, so how did I reach that? Because of the anatomy. I know this is the genicular ganglion, and it's easy. When I see osteolytic lesion here, I know that the diagnosis is facial nerve, either hemangioma or schwannoma. And also Bell's palsy, we never do that by imaging, but sometimes it happens. But if you look at a case of Bell's palsy, which is just inflammation of the facial nerve, it has very subtle findings, but because you know the anatomy, this is the stylomastoid segment where the facial nerve exits, and you can see this landmark is the stylomastoid artery here that is very close to the nerve. Compare this to the right side, which is faintly seen. So you know that the patient has left side. It's something here related to the facial nerve. You can also see it here on the cis plane, and you compare it to the other side. Sometimes DWI is very helpful because you can localize facial nerve pathology here that is not seen on the right side. And even on coronal view, you can see the whole mastoid segment, vertical one that I've shown you before, and then you compare it to the other side, so you can make diagnosis of Bell's palsy, of course, in the appropriate clinical context. And then before leaving this part, I want to show you a case of facial hemispasm. When you because actually vascular loops, as we discussed before with trigeminal nerve, vascular loops can also occur near the facial nerve, and you can see here this is a case of facial nerve compression by a vascular loop here can arise from the ICA or the pica. This case actually you'll see here on T2 3D imaging. You'll see this nice appearance, appearance of a loop here. This loop, you see the vertebral arteries here, and there is a loop here of vessels that is touching the facial nerve here in the cistern. So a vascular loop, probably from the ICA, from the pica, or sometimes from vertebral artery itself, can cause facial hemispasm, of course, in the appropriate clinical context. Before leaving the facial nerve, I've just seen this case today in the morning. This case I just added this before the lecture, but it's really very interesting. And and when I saw the case today in the morning, I just included it in my lecture. And let me exactly tell you the story. What happened? A neurosurgeon came to me last week and he showed me this MRI for this patient who has a space occupying lesion here in the right middle cranial fossa. And the question was, is it intraaxial or extraaxial? And I had the feeling from this T2 that there is something here that is like a plate of bone, maybe a cortex, something black here around, just in between the lesion and the temporal lobe. And my impression was, I said, yes, it's extraaxial, but I have one more concern. That is, there is a possibility that this lesion is not from the dura, it's not extraaxial, intracranial, but it's coming off from the bone. So I had this impression, and even when we gave contrast media, we give contrast, and the lesion looks ugly, as you see here. It's ring enhancing, it has necrotic core. The lesion looks in the axial plane, you can't judge exactly where is it coming from. But when you look at this part, you have the same, I think you share me my thoughts or my feeling that this lesion could be arising from the petrous itself. It's not trigeminal, it's not cavernous sinus, it's not related to the anatomy that we know, but it's along the anterior surface of the petrous bone. What we did in the morning is that we asked the patient to come and do high resolution CT of the petrous bone. And let me tell you exactly what did we find. So first of all, we found this surprise. Yes, here. So we found erosion here of the petrous apex and the petrous ridge itself. And there's erosion and there's scalloping. And what else? Look carefully at the lesion. I think you will be able to notice this. So there is a border here, the border here of the bone. So yes, it's expansile osteolytic lesion with a cortical plate that is really very thin. You have a very thin cortical plate here around the lesion. I think you can appreciate it here. There's something here in this location. The other thing that I noticed is this part, because I know the anatomy of the facial nerve. It should be here at this area. So there's some thickening here of the facial nerve. But before going to this point, what is this? What is this location? Because this is the internal auditory canal here. So you have the canal, and then the nerve goes this way in between the cochlea and vestibule. And before making the V, the inverted V, it goes to this point where the geniculate ganglion is located. So the geniculate ganglion is involved, and there is something that protruding from the geniculate ganglion, expanding all the way through the petrous bone with scalloping and with some kind of bony erosion, as you can see here. So this might be a facial nerve pathology. When we did the coronal, things were very clear. You know why? Because actually I did what I just taught you to do. I went through the images, the coronal images, until I was able to see this. This is the snail's eye. Remember that. This is the cochlea, and these are the two nerves. We've just seen that. This is the labyrinthine part, and this is the tympanic segment. And I will put this just for comparison. This is the other side. You have here the two dots, and you have a thick bone here. Here the bone is gone, and this segment is gone by the eroded bone here on the surface. What else do we have? This is the main surprise. This is the real fun is coming now. Here, this is the lateral semicircular canal, and I showed you this before. Look at the lateral semicircular canal and the coronal. Look under the lateral semicircular canal. There should be a facial nerve, which is very thick in this image compared to the other side, which I put here for comparison. See how tiny is the facial nerve normal on the other side, and how thick is this one on the affected side. That establishes your diagnosis that you have a facial nerve pathology. But because of the pattern of bone erosion, this is a schwannoma. This is not a hemangioma. The hemangioma has some permeative erosion, some bony specules inside. Here you have just scalloping, you have bony expansion, so it's a schwannoma of the facial nerve, just based on your knowledge in anatomy. Now let's move to vestibular schwannoma. This is a very common lesion. Everyone knows what's vestibular schwannoma. I'm going to show you this case very quickly. You have here coronal view with contrast, post-contrast, and you have this enhancement here in the course of the left internal auditory canal. And you can see it here, you can see the contrast here, and also on the cis images, axial images, you'll be able to see. And by the way, this sequence is comparable to contrast, so it gives you almost the same results in terms of accuracy. So you see the lesion here. But what I want to add to these cases, so we see these cases many times. So there are three things that I really want you to focus on and try to include this in your report. Number one is that try to measure the part in the cistern and the other part in the canal. So because it's important. So size matters here to the surgeon, to the neurosurgeon, because surgeons need to know what's the component in the cistern and compared to the other component in the canal, because surgical approach will be different. And the other thing is that try to find out if there are any loops, any vascular loops. You see here, this is the ICA, and try to go with the ICA here. You can see it here, and to make sure that it's not looping inside the canal. In this case, it's not. It's important for surgical, as a surgical, safety procedure. So try to make sure that the ICA is not looping inside, and sometimes you can measure how far does it go inside the canal. And number three is the most important one. Try to find out if there is translabyrinthine extension or not. Try to find out or to make sure that the lesion did not violate the labyrinth, did not go further beyond the borders of the vestibule or the cochlea. So it stopped here at the fundus of the internal auditory canal. But if it goes beyond these borders, beyond the cochlea or vestibule, then there is translabyrinthine extension. Why is that is important? Because we have different surgical approaches, and one of them is a translabyrinthine approach. And if you can imagine that the translabyrinthine will go through the labyrinth, so it will sacrifice hearing for this patient. So if the patient has any potential that the lesion has not yet invaded or infiltrated the labyrinth or extended through the labyrinth, so that means that the patient can keep hearing after surgery. And this might change the surgeon decision to do both retrosigmoid or middle cranial fossa approaches, which will preserve hearing. So these approaches are called hearing preservation or hearing preserving surgical approaches for vestibular schwannoma. So these are the three things that I really want to mention in my report or include in my report. And then let's move to the next question. Question number 5. A transmacular extension of vestibular schwannoma results in tumor growth into A, internal auditory canal, B, cochlea, C, vestibule, or D, middle ear. Well, so it looks like the question is tough. So the correct answer is the vestibule. And this is what I want to, it's just a very simple note here. This is the same patient, and we see here the lesion here, the internal auditory canal, and this is the cochlea. Remember, the cochlea is anterior and the vestibule is posterior. So once the lesion violated the vestibule, it will violate the vestibule, or it extend the vestibule through an opening here, which is called the macula. And if it did the same thing but with the cochlea, so it will violate the border here and extend into the cochlea through what's called the modulus. So a cochlear extension is called transmodular extension because it goes through the modulus of the cochlea, and it does the same thing to the vestibule. It will go through the macula, and here we'll call it transmacular extension to the vestibule. So this is what you need to include in your report. Another case of vestibular schwannoma, very classic case. As you see, you have this funny shape of an ice cream cone. You have the extension through the internal auditory canal. This is important because that helps you differentiate the schwannoma from a meningioma, which is not uncommon to form here. And what's next in your report? You need to report and mention in your report or include in your report this mass effect of the lesion on the pons brain stem, on the prepontine cistern with basilar artery, how close the lesion from the basilar artery, and this partial effacement of the fourth ventricle, which is really important in these cases. And you can see here, I've seen this case very recently with a vestibular schwannoma, a large one, in a patient who came in acute deterioration, acute exacerbation, if you will. And what's found here, we see the lesion here with multicystic areas, and also you see this hemorrhage and SWI, so the lesion bled. So a hemorrhage in a schwannoma is not uncommon. Cystic changes in a schwannoma are not uncommon. So you need to mention this in your report, and that can happen because, cystic areas in schwannoma, especially if it gets large. A schwannoma, when it gets large, it exceeds the perfusion of the lesion by blood supply, and then it can undergo some sort of necrotic changes or cystic degeneration. Of course, this has also some histology background because there's Anthony type A, Anthony type B. So we're not going to go in these details now. But what I want to show you also is the contrast images here, where you can see the lesion has these cystic areas inside. But what's important in this patient is the hydrocephalus again. So try to mention in your report, don't just focus on the schwannoma and forget that the basilar artery is very close to the lesion. You need to mention this in your report, and also the mass effect, the severe, significant mass effect on the brain stem and on the fourth ventricle, and of course the obstructive hydrocephalus that is developed. Now, before I end this section, I have to show you this case with bilateral symmetric enhancement of the vestibulocochlear nerves, and you can see some sort of thickening here. That can occur due to many reasons. There's a long list of causes that can cause something like that, other than tumors, of course. But in a patient who has a primary cancer, this could be due to leptomeningeal carcinomatosis or metastasis. But also infections like Lyme disease and some viral infections, Ramsay-Hunt syndrome, and also non-infectious inflammatory, systemic inflammatory disorders, such as sarcoidosis, for example, can give something like that. Now let's move to the 9, 10, 11. And I'll show you very quickly a case here with this lesion. And we have here a coronal that, and again, here's the lesion. And I want you to focus on these two lesions before answering my next question. What's the most likely diagnosis in this case? Is it A, schwannoma, B, meningioma, C, paraganglioma, or D, none of the above? Okay, good. So actually, this is not a schwannoma, but this is actually a meningioma. But let me think of, this is a foramen. This is a jugular foramen lesion. So when you see a jugular foramen lesion, there are two main categories, three main categories, the three main entities in jugular foramen lesions: schwannomas, meningiomas, and paragangliomas. So these are the three big guys that occur here, that come here. Okay, so this one is a meningioma. Why it's a meningioma? So I would call this, the signal intensity wise, like you see this lesion that is IG intensive, the gray matter. It has a globular contour. It displaces the internal jugular here. So it acts like a meningioma, but you can't rely on these features. There should be some other clues, by the way. So I agree that it could be a schwannoma. This has to be included in the differential. So, but you can see here, there's a dural tail, a small dural tail here. So all these features together will support the diagnosis of a meningioma. But let's get some sort of teaching points out of this. So what's the landmark first? What's the landmark for 9, 10, 11? 9, 10, 11, the three nerves go through the jugular foramen. So to identify this on imaging, you start first by identifying 7 and 8. So once you see 7 and 8, 9, 10, and 11 will go down, will be a level just below that level. The other clue is the proximity of the jugular foramen to the venous structure here, the jugular and sigmoid. So once you see the jugular vein, you know that the jugular foramen is very close. It's actually it will be hitting the vein, and we'll see that in a second. So this is another quiz case, and I'll show you very quickly. And the hint here will be the jugular tubercle. I just want you to look at the jugular tubercle. Where is the jugular tubercle? And because we have another lesion here we have another lesion, and that is the lesion is seen here on axial images. And then where is the jugular tubercle? The lesion, is it above or below? I want to skip the question. I think we only have 15 minutes, Ryan, so I'm sorry about that. I want to skip the question and I'll show the answer. The lesion is above the jugular tubercle. So your first clue is to identify where is the jugular tubercle, and I will tell you how to do that. What you need to do is to scroll the images until you find the odontoid process. So once you see the odontoid process here, you see it here, then just above the odontoid process is C2. So this is C1, lateral masses is C1, and C1 is articulating with the atlas. and you have here the atlas on both sides. Once you see this appearance, this shape of a bird beak or eagle beak. So you see this bird beak, you know, this is the jugular tubercle, and this is the beak. The beak is important because the area just superior and superior lateral to the tubercle is the jugular foramen. So a lesion here would be one of three, mainly schwannoma, meningioma, and paraganglioma. But a lesion that is below the beak, this area is the hypoglossal canal. So remember that carefully. So you see the tubercle is very easy. Scroll the images until on the coronal, until you see the odontoid process. You have here the jugular tubercle. Above the jugular tubercle and to the lateral side is the jugular foramen, where we have 9, 10, and 11. And below the beak here, you will see the hypoglossal canal, where you have the hypoglossal nerve. So this case was a schwannoma, and then let me show you the third case here, where you have a paraganglioma. So again, this is the axial images, and you see the lesion also in the axial images here. Easy to see, it's not hard. And then on T1, you see the lesion with this characteristic appearance on T1 that is actually heterogeneous. There are hyper intensities with dots of dark areas or flow voids inside. We call this salt and pepper appearance, and this is of course very highly suggestive of a paraganglioma or gloma jugulare. And by the way, you can see the salt, and this is again the salt and pepper appearance also. And look at the beak, look at the eagle beak here, it's very nicely demonstrated in this case. And you can see here on the T2, again, same thing again. So now you can make sure that the lesion is coming from the jugular foramen while the hypoglossal canal is clear. So then the diagnosis would be a paraganglioma. So the signature of glomas or paragangliomas are both salt and pepper appearance on MR, and the other thing is CT. CT is really helpful in these cases because these specules, this permeated appearance, once you see these specules and permeated appearance, you establish your diagnosis of glomas, again, the Barrett. So I'll skip this part. CT is my friend when I evaluate the jugular foramen, because you have the two pars nervosa and pars vascularis. Pars nervosa is anterior, pars vascularis is posterior. The vascularis is always big, the nervosa is the small one. And the same rule will apply when you split the anatomy here. When you see the anatomy, you have 3 cranial nerves, 9, 10, and 11. So the big one will take 2 of them, and the small one will take 1 of them. And we have also vascular structures. The big one will take the internal jugular vein because it's the big one, and you have the small one will take only the inferior petrosal sinus because it's a petrosal sinus. It's a thin, small one. The coronal images, again, look at the Barrett, look at the beak here. Sorry, look at the beak of the bird. Look at the beak of the eagle or the bird, and you have here 10 and 11, have 9. So the area just superior and lateral to the beak is the foramen, the jugular foramen, and the area below the bird beak or the eagle beak is the hypoglossal canal. So how CT could be very helpful in differentiating the 3 big ones, schwannoma, meningioma, and paraganglioma. In schwannoma, as I told you, there is resorption, yes, but it's pressure-induced resorption. There's no specules of bone, no permeated appearance. It's only expansion. It's osteolysis, as you can see, and pressure-induced resorption here with this remodeling, if you will, or scalloping of the border here. And you can see even the jugular tubercle, this is the normal side, and this is the affected side. The lesion is expanding all this area and is taking out, it's eating the bone here without any specules, without any permeated appearance. Even the tubercle itself is gone just by pressure-induced resorption. This is schwannoma. This is what does schwannoma do. Meningioma does not do that. Meningioma can do hyperestosis in 5 to 10% of cases. Of course, it can invade bone, but in malignant forms of meningioma. This is not the usual case. This is not the classic case. But for schwannoma, it's really helpful. So what about glomas? As I told you, permeative appearance. So it's same thing, expansion, osteolysis, but permeative appearance, bony specules. Even this part of the tubercle is gone because of the bony specules. And what else? Salt and pepper appearance. So this will help you. First of all, where's the lesion? Jugular foramen. How did I know? From coronal. I got this shape of the eagle beak. the lesion just superior and lateral, so it's a jugular foramen. What's present here? We have 9, 10, and 11. So what's the shape? What's the signal intensity? Salt and pepper. How about CT? Specules and permeative appearance. So it's a glomus. And also remember to look at the denervation, as I told you before many times. Always, whenever you have a motor nerve, you look for the denervation changes of the nerve. And of course, since we have the vagus, number 10, then why not to look at recurrent laryngeal nerve palsy, which in this case, you can see laryngeal or vocal cord paralysis with all these features, medialization of the air epiglottic fold, with widening of the piriform sinus, this shouldering of the vocal cord and rotation or medially rotation of the arytenoid cartilage. So all this will help you make a diagnosis um, of jugular foramen lesion. Now, the last one, the last nerve, number 12, before time, we'll make it on time. So I'm showing you this patient. This patient has neurofibromatosis 2, and you're seeing now the axial T1 pre-contrast. And you have many lesions. I think you can see there are many chunky masses, and you have here the cis sequence, high resolution sequence. Again, you see the same lesions again, and then you have also contrast, post contrast, and you have here bilateral something. You have below here, down here, you have here the something related to the again jugular foramen slash hypoglossal maybe. And then even here, when you look at the cavernous sinuses, you have something here filling the cavernous sinuses, trigeminal nerve as well. And you have many other lesions, and even above higher levels of the brain, you'll see there's something here, another thing here. My question with this patient of NF2, my neurofibromatosis 2, would be the last question in the session today, which is neurofibromatosis 2 is characterized by all the following except A, schwannomas, B, meningiomas, C, neurofibromas, or D, ependymomas. Well, so we have, okay, so we've got some sort of split of the answer here. So let me remind you with this. So always remember that neurofibromatosis 2 is a multiple inherited meningiomas, schwannomas, and ependymomas, and we call it MSME. Multiple schwannomas, meningiomas, and ependymomas, MSME. But ependymomas are not intracranial. They are always spinal, but they are ependymomas at the end of the day. But the only thing that is not present with NF2 is neurofibromas, which doesn't make any sense because it's called neurofibromatosis. Yes, it's a neurofibromatosis, but it's type 2. Type 1 is the only one that has neurofibromas. Type 2 does not have neurofibromas. So the correct answer is neurofibromas. And then I'm going to show you this case very quickly. Here you have this patient has, this is the same patient we're seeing now with neurofibromatosis, but I'll show you something here that the patient actually came. We know that this patient has NF2 and he's been under follow-up for years. And then recently he started to develop some sort of dysarthria. He can't speak very well. He has some sort of deviation of the tongue. And then he came to the hospital and we were concerned about anything intracranial new, ischemic, stroke-like, blah, blah, blah. And then we did imaging and we found the same schwannomas that we've used to see before and also here in this location. And then we did the coronal, and also, again, let me remind you with this. This is the bird beak. This is the eagle on the left side. And on the right side, there's something here under the beak. Under the beak means that we are dealing with what? Hypoglossal canal, something. So there is a lesion here in the hypoglossal canal. And this was the clue. Yes, I know there are multiple schwannomas, bilateral vestibular, trigeminal, cavernous sinus schwannomas, and also even glossopharyngeal, jugular foramen lesions, multiple, but that does not explain the dysarthria. That does not explain the tongue deviation or the tongue problem that the patient recently developed, but this does. This location does explain that, and at least it rules out any other thinking or any other thoughts of stroke or any acute other insults to the brain. So what should we do now? Motor denervation. That will establish the diagnosis in almost all cranial nerves which have motor which have motor parts or motor fibers. Look at this. You see this. This is denervation changes in the right side of the tongue. And also on T2, you see the signal here due to edema in the right side of the tongue. So now you are comfortable saying a reliable diagnosis that you have a hypoglossal schwannoma as part of the multiple schwannomas that the patient developed in the past and still developing, but at least that explains what's happening to the patient now. Let me remind you with the anatomy of the hypoglossal nerve here. So it's not easy to see, to separate the hypoglossal nerve from the other jugular foramen nerve, but I will teach you how to do that. But at least the same clues again, you have 7, 8, below 7, 8, you'll see 9, 10, and 11, and more anteriorly, just more anteriorly and medially, just more medially, very slightly, you will see the number 12, and that might be also in a, a lower level. The difference is not big, just one slice below this level. So imagine that you're seeing 9, 10, and 11 now in the jugular foramen, just inferior to this level, and more medially you will be able to see number 12. But again, the main clue, the helpful clue will be the coronal, because the bird beak. Once you see the bird beak, above and lateral is jugular foramen, 9, 10, 11. Below is number 12. What other clues do we have? The vertebral artery. Vertebral artery could also be one of the clues, that because the nerve is here, just posterior to the vertebral artery. You can't rely on this in all cases, because vertebral artery itself can have some tortuous course, or be dominant, or maybe hypoplastic in some cases, as you can even see here in this case. But let me show you exactly what do we have here. So you see, this is the opening. This is the jugular, the hypoglossal canal itself. So see, this is the hypoglossal canal, and the hypoglossal canal is here. And you can get this again by going axial just below the jugular foramen. You will see the hypoglossal canal. So I can tell, and I think you share me the same feeling, that it's not easy to see the hypoglossal nerve. Yes, it comes out from the ventral sulcus, but it's not easy to see it. It's posterior to the vertebral artery, but the nerve is still faint and thin. But when it exits here, as you can see here, through the canal, this could be some sort of a helpful feature. As you see in this case, this is another case of hypoglossal schwannoma, but I would show you how this was easy, kind of, to how was it easy to make this diagnosis, because when you look here, when you scroll here, trying to find out where is the hypoglossal canal, I think you'll be able to see this part here. See, this is the nerve. The nerve is here, and it's coming off here. It's coursing here towards the hypoglossal canal. So it's exiting from this part, and the vertebral artery is here. So the nerve is probably behind it. So, and on the other side, on the same location, you see this lesion. That's why you can make your diagnosis based on this comparison to the other side. The lesion here is hypoglossal schwannoma. But again, as I told you, it's much easier when you do this in a coronal, because the coronal will help you identify the beak and look under the tubercle, jugular tubercle. But we can't leave the hypoglossal nerve without talking about loops, because of the location and proximity to the vertebral artery that makes this nerve vulnerable to any kind of neurovascular compression by the ICA, by the pica, which is more common, or even by the vertebral artery itself. Sometimes you get aneurysms here or any other vascular structures, or maybe a developmental anomaly like persistent hypoglossal artery in some cases. That's it. Yeah, I think we are on time, and thank you for paying the attention.